Good afternoon, everybody. This is Pat with the Colorado Gerontological Society, and we are on session 2 on Reboot Your Quality Management Plan and moving on. So we're going to tackle another portion of it. We have available part 1 that's recorded that you're welcome to look at and catch up if you missed part 1. So we're going to move on. So in the review of part 1, the things that I asked you to start thinking about is to look at your plan, and is everything still relevant? And is everything executable? In other words, can you do it? Is the whole team on board, as well as the residents? And did anything derail your organization last year? And do not include COVID in this, because that is a whole separate entity. Okay. So why do we want to tackle this now? Well, remember, quality is a process. And every day you have to weigh in what works for that day and what's not working. And a lot of times you have to pivot on a dime. You may have to change things up fairly quick, and that you may also be able to plan to change things up. And that is just part of normal business. The quality of it, though, is the constant of it. So what you always want to do is, you think quality is that you're taking all the stuff you do and take credit for it. But the second part of it is to organize it around your everyday issues of being a manager. So some key concepts is, why in the world did we got to catch this up now? And haven't we had enough? Well, the reality, this is a perfect time to catch it up. So one is a gift. It's a gift from you to you, and it is helping you get your thoughts in order so that you're ready for anything else that anybody could put in your way of being successful this year. It's also a time to think about your emotions. One of the things I discovered in December is how exhausted I was with COVID. I really didn't want to hear another word about it or have another person die in my life. And from the time I thought about that till currently, I've had more than 20 people die in my life from COVID. So, that didn't exactly work, but I'm coping with it better. So my emotions are more in check. And what I did is I walked back and started filling back some of my life of the things that I love, which I like to read. And I also have a huge studio, and I like to do different things, different times of the year in my studio. And so I got on my studio, I tore it totally up. I found stuff I haven't looked at in years, and I'm reorganizing my whole studio. And I actually made a quilt between Christmas and New Year's, 96 by 96 inch quilt that I call the COVID quilt. So it'll be going on the long arm here in a couple of weeks, and it will be my memento. I made a wall hanging to go with it that I am beading, and I will put here in the office. So that helped me. It helped me realign and regroup and kind of think through and deal with the emotional aspects that COVID put us all through. Okay. But in your case, I also want you not only to go find some of the things that made you happy, put them back in your life, but I also want you to think about, why did you get in the assisted living world in the first place? What's your love for the older adults? What's your commitment to seniors? What's your commitment to memory care? What's your commitment in being a women business owner or a small business owner? So think about the original reason that you're there, and when you come up with some clarity on that, would you write it down? Because every once in a while you're going to have to look at it again, I'm pretty sure. So COVID emotions are lingering all over the world, but we're actually putting words to it. So you'll hear Zoom fatigue, or you'll hear people say they feel guilty for living when other people in their family died, and they call that immoral COVID. And there's some really, interesting discussions coming up around how we responded in the management world and how we need to take care of ourselves as well as take care of other people. Relias has a cool new program. It's called Crisis and Chaos. For those of you that have Relias accounts, I would encourage your staff to take it. It's about a 40-minute training, but it puts language to the emotions. And if you don't have Relias, consider using Relias as one of your training modules. They're really well done, and they're vetted, and they're considered professional trainings. So quality is used daily in our lives. We do it every day, day in and day out. Some of us are more routine than others, or others are more spontaneous than others. I'm a routine person. I like things to stay pretty much in those boxes. And I, especially in a lot of things in my private life, I don't like change very much. And I just want them to work. I want my TV cable to work. I want my phone to work. I want my internet to work. Or any of that stuff crashes, then it's very irritating and it takes a lot of energy to get it fixed. So we use quality all the time. I had somebody say to me yesterday that quality is easy. And I'm like, well, not in my life. Quality is consistent and it's important, but it's not particularly easy. Though I do think with organization, we can make it easier than with lack of organization. I also want you to acknowledge that social media has changed everything about quality. So we get something posted and a lot of noise around that posting, whether it's true or not. And then it all of a sudden becomes the truth. And it gets, it's worse than the old gossip can program where you put two cans on a string and put a message through. And by the time it got to the last person, it had nothing to do with the original message. That's kind of how I see social media, is that it's not always meaningful, and the feedback may not always be meaningful. But sometimes it's really rapid fire and short lived, and other times it shows back up years later and it's revisited. You do need to pay attention to social media for your facility. So long term, the things that we really need to think about is we need to pivot on a dime when we have complaints, make sure that we are dealing with the emotion of the complaint as well as the words of the complaint. So quality, think of quality in the long run as an accumulation of situations and they need addressed. And if you don't address, they just fester and fester and fester until they blow up. And in our work here in our office, we see a lot of that explosion stuff where people try to work on something and they can't solve it. And then it all blows up in their face. And then when they hit our office, they don't have one issue. They come with multiple issues. So I get to prioritize those issues and figure out what we can or cannot do. That's an action plan. It's the same thing that you do every day. So when you go into the facility in the morning, you may think it's going to run one way, and before 2 hours is over, you got a whole different action going on. And that's your pivoting and the things you guys have learned to do so extremely well. So in the long run for quality, I want you to think of it as a nice walk and that you're going to just really diffuse and get rid of all that negative energy and think through of things that could be useful and make you happy. Most of the stuff you deal with, even COVID now, you have experience with, and you have a lot of action steps. Sometimes they're not in the right order, or you need to revise them, or sometimes you got to throw out an action step and replace it. But the big thing is I want you to think about it as mitigation. You really want to have the days as routine and boring as possible, and then fill those boring gaps with fun activities, stories, music, things that make everybody happy, and not dwell so much on all the negativity that we're seeing. So in the process, I want to kind of help you guys think about how we get some of the stuff in our life. So we get laws from the federal government that our congressmen and our senators think up, and they give feedback, and a whole pile of people work on it, and then they present it and they vote on it, and then we have a law, and then the law goes to the cabinets or to the departments that they impact, and then they go through this great big old long process. Part of that process is they negotiate with states. So the vaccines is a great example of this. So we got an emergency order, an executive order to produce vaccines quickly and get them approved in rapid fashion. And so that became a law in the Cures Act, and it was revised in executive orders, all that overlay. It went to different departments in the cabinet to actually execute it. And in part of the execution, they started talking to the states, and the states started talking to the feds about how to do it with best practices and what their state could tolerate or not tolerate. and the states made negotiations. So some states did absolutely nothing and got nothing. Other states were very, very positive, Colorado being one of them, and we have had great results. We have gotten good loads of vaccines, we have gotten blessings for programs, and we have been actually on the forefront. We've done well as a state in the COVID response. And like I said, some states have done nothing, and now they are upset because they don't have any vaccine to buy because they never bid on it back when the bidding started. So sometimes when it falls down in the states, you have to figure out who's paying for it. And this is a big issue for every state and every municipality, is who in the world is going to pay for what and out of what budget's going to come, because our budgets are tight as a drum and they really don't have a lot of room. And so a lot of times in the work that I get to participate in, we look at what we call shared products. So the feds may pay a portion, the state may pay a portion, the local may pay a portion, or the foundations may donate money to doing research, or they may give us a grant to do research. So money comes from a variety of places, but every discussion that I go to that involves our industry is they're looking at what percent does the state have to come up with and what percent does the feds contribute. And so that's why we have such a huge national deficit. So remember, in Colorado, we're not allowed to be in the hole. So we have to pay for everything we're doing. And that is adjusted quarterly based off of money and revenue that's coming in from state taxes. There's a few programs that are totally state funded. And that, there's small programs, and if you run out of money for that program goes away. We do better when we have federal match dollars for most programs, though it's very interesting to see those percentages and what the state can con out of the feds. So in the state process, we get statutes, and that goes through legislation, and then we get written documentation, and then again it goes down to the different divisions through the cabinets, and then they go through their vetting process. And then in our case, we have medical boards at the Department of Human Services and at the Healthcare Policy and Finance that review everything and say yay or nay. And then it gets disseminated on down the line. In our world, one of those worlds is the health department. It's a subgroup, and they're tasked for regulating and partnering with the entities for enforcement. So a lot of times when we're talking to legislators, they really don't have a good vision of what's happening at the health department. So we have been specifically working to make sure they have the right information for the right programs and the impact. And I can tell you the community has really been burning the ears off of legislators for the last 2 years. So back even 3 years ago, if they got 4 or 5, 6 comments on anything they were working on, it's considered a miracle. When I'm talking to legislators, they're filtering through hundreds of comments and phone calls and feedback loops. So their job is significantly more impacted by community than it's ever been. So the regulations, even at the health department, are based off of what we call stakeholder groups. They're driven by feedback and guidance. And so the stakeholder process can be fairly long in some projects and fairly short in others. And so our small group assisted living and our assisted living meetings that we have quarterly with the health department are an important part of it. And you should be there, and you should be bringing your information and feeding it, because like every other entity, they were getting little snippets of information. Now they're getting a lot of information, and sometimes it's hard to figure out what belongs and what doesn't belong. So one of the example I can give you is that there was a long discussion about what belongs in orientation. And there was people having an hour's worth of orientation to the facility, and they were left alone and out the door, and nobody was there to support their questions or help solve issues. And that's no longer tolerable. You have to have a very robust orientation program. You have to have a very robust onboarding and competency program. So those changes came from the challenges that seniors were experiencing, their families. Surveyors would go in the facility and what they were reviewing. So a lot of feedback loops came in, and then a lot of change came in orientation. I even expect orientation to be expanded in the next rewrite. Policies In all levels. Everybody has policies to function, and those are community agreements. But the big thing on the legal side is to mitigate. And so mitigating and predicting situations and having the right tools in place is what drives a policy. As for those of you who's been working with me on QMP for a while, you know I'm a big fan of having a QMP notebook. I don't care whether it's electronic or paper or both, but a QMP notebook is important because it's broken into parts. And those parts are also known as elements. And the elements have handshakes with each other in their processes, which then develop into policies, and then you train them in what I call how-tos. So when lawyers write policies and procedures, they are for the lens of court. When we write policies and procedures for our industry, for our homes, it is more on the actionable step. And that's why policies have to be updated every year and reviewed to make sure that they're functional. And that's part of your quality work that you do yearly is you review all your resident service agreements, your fire, because fire just changed recently. Other parts of our work in the industry, you have to go through and review. So the notebook can be really helpful, and tracking tools are extremely helpful because it's proof in the pudding that you did the work you said you were going to do. So that's element one, recap. Element two is how do you coordinate the responsibilities? One of the fallacies that I see in the industry is they think the administrator has to do it all. The administrator is the coordinator. It is actually delegated and given to different departments and to help build skills into other departments and give people some responsibility. So it's kind of like raising kids. If you do everything for your kid, and then when they're 19 and they go to move out and they can't do anything for themselves, you have done a disservice to your kid. So most parents, give kids what they call age-appropriate tasks or activities to do to build their confidence and their ability to live on their own. We have to do the same thing in our industry. So quality belongs to the whole team, okay? And residents are part of your feedback loop. Sometimes they're informal and sometimes they're formal. So again, when surveyors go out and they ask the residents, how do you like living here? And the residents go off on a tangent and start complaining 100 miles an hour. Then they'll say, well, did you tell the staff? And they'll say, sure, I told XYZ. And then you talk to that staff person and they did nothing with it. That's a breakdown in the cycle. And so one of the POC areas that I'm seeing written up quite a bit is on the grievance and complaint policies. We have tried in the industry over the years to do it in resident meetings, to do it with a complaint box. The big thing is whatever methodology you do, get it in writing. And then when the residents have a situation that if they can't write anymore because of health or mentation, that when the staff person does it, and I don't care how trivial it is, because the POCs that are coming through that I'm getting to see are pretty trivial things. And especially in memory care, because I've had personal experience with my own mother in that, where she took everybody's belongings and we had to go through her room fairly often and return everybody's things back to them. So no matter what the complaint is, do not blow it off or dismiss it, okay? And then the best way to actually do quality is in what I call huddling. Formal meetings, people just shut down and they don't listen to you or contribute, or they think that somebody's going to judge them for speaking up. When you do small huddles, you'll actually get a better feedback loop and you'll actually get more information than you will in your formal staff meetings. And those impromptu discussions, again, are for you to glean information and figure out what they're talking about. I like to give leads projects and have them feel like they're part of the pie and their contribution's important and it's part of their growth and also part of their ability to get raises. So I use leads projects a lot when I was working in a bigger setting than I do today. But we even do it here. I mean, all of us have different projects that we're lead on and that we're responsible for, okay? We have to work on developing some research skills with our staff. Some of our staff are incredibly good on the net and they know how to make the net sing. And so, and others haven't had any experience. So maybe partnering two of them and building the skill sets up. One of the things that I learned in my old work is that when staff came to me with, I think, immediately was not valuable. So when they came to me with, we have evaluated, we are seeing this and it's repetitive and it continues to happen. And we went and looked, and this is the regulation that this center is working off, or this is the policy this center is working off, or this is what the seniors are getting in the mail. Then we take, I think, to more viable documentation tools that we can figure out what we can do with it. Because not everything's clear as a bell, not everything needs changed at the moment. Sometimes you got to gather data and information, and not all data is numbers. It may be you have 5 complaints on this or that. That's numbers. But you may have, 5 different viewpoints of something at the house that people see differently. And then you have to weigh it and figure out if you can change it or not. So coordination is work. And one of the things that's important about that is that when you give quality initiatives, you got to give the time for the people to do it. So some facilities will pay for an hour for the person to do the work at home, or they'll pay for an hour to go to training. And they feel that that is a good investment in their facility. Other facilities have the ability to do it on site and maybe have some extra staffing. And a lot of facilities don't do anything, and then they're constantly behind. I encourage you to find a way to coordinate and get the feedback loops going. You do not have to own every project. So element 3 is, how do we do a systematic approach? So a systematic approach is broken into parts. So who's the lead person? Who's going to do the reports and get them into me and fill out the tool that so that I can show that we're working on this? And did I give an assignment? So you give somebody an assignment, they're reporting, they're seeing this, this, and this, and you give an assignment. Okay, I need you to gather this information, and I want you to go find out what is going on in the industry and how we can do it better, and then check regulations on Chapter 7 or the fire regulations or whatever you're working on, and see what they can find. And then they do absolutely nothing, then that's a problem. So you have to find ways to encourage them and to make them feel valuable. Okay. And then some projects may need a lot of review, especially if it's something emergent or urgent. Had we done better a year ago in our industry in the response to COVID? Had we had the right tools? Had we had the right information, we would have reacted better. Our death rate would have been a lot less. So the over 6,000 people that have died in our state, 60% of them are out of facilities. Nursing homes, assisted living, group homes, that type of stuff. And so again, the red arrows over our industry because we had the highest percentage of death. All right, so remember, again, you don't have to carry the issues alone. Delegate. Be very clear in the responsibilities, be very clear in the feedback loop, bring it back to the team and talk about it before you make a quick executive decision. And I'm going to, these are the rules and this is how we're going to do it. If you can, bring it back and try to work on best practice and collective agreement. You'll have more buy-in and more consistency. And every once in a while, when you bring it back to the group, and this happened to me a lot in my old work life, a light bulb moment would come on. And I had, I've been struggling with the topic, or I couldn't figure out, the root cause. It didn't make any sense to me. And then all of a sudden somebody said something and the light bulb came on and I got it. Okay. So in your world as an administrator, always think about you are the coordinator unless you have a dedicated quality manager, okay? So try to stay to the facts. Try to stay as far away from the I think model, okay? Try to understand that in Chapter 7, they give overview regulations. They don't give you the detail. So you're responsible in your policies to reflect Chapter 7. So when I write a policy, then we will put the coordinating regulatory oversight to it, and or a statute if it comes from like OSHA or something like that. And then we build around that. So we always have a reference point. And those reference points are saving grace when state comes in and says, you're not doing this or this or this right. And I have said to surveyors, please show me in the regulation where you are recording that from, because they do a lot of interpretation and make it truth. And then we have had a real challenge, especially in the last 6 months, of fighting back. And they will cite multiple places where they believe that truth comes from and give multiple tags. And that's one of the things I've seen with the facilities that have allowed me to participate with them and help them write their POCs. All right, so written tools. These are a list of some of them that you should have in your staff meeting. Should always have minutes. Change that responsibility up and have different people take the staff meetings, have a tool to fill in. And then don't worry about spelling. That should not be your focus, so it will drive some of you crazy. What's more important is that they actually capture the information. So you should have an agenda, and then they can capture the feedback loops. They should have who attended and the date and time. Those are important. CARE conferences are super important. They need to be written down. And again, who attended, the date. You're required to have at least 1 a year. Doesn't mean that 1 a year is all you should have. If you have people that are unstable, you may be having 1 a week. You may be having 1 a month. If you have hospice or palliative clients, you're going to have 1 a week or 1 every couple of weeks when they're stable in their palliative care. So CARE conferences should be fluid, but they are a documentation tool. Surveys. Your surveys are available on the portal. Some companies print their surveys, put them in a notebook for public view. Others do not. It all depends on what your philosophy is. Grievance and complaint forms are very viable and very helpful to keep those gathered. And again, this is where data comes. So you're tracking your complaints, and they circle. You might have like 6 main areas of complaints, and they can circle what their topic's about. And then you review those on a quarterly basis, and you log them in, and you track and trend. And I'll be teaching that in a future session. And then watch for feedback loops with resident meetings, staff meetings, family meetings, whatever you're doing. Try to grab your feedback, and again, don't let it roll off your shoulder and just poo-poo it. Take it seriously and try to decide just, where does it fit? And is it something that we can work with the resident on? Is it something we have to work with the family on? Can we come to agreements? Can we adjust the care plan? Or do we need to help this family find a different place to live that is more accommodating to their needs? So we're going to start a work plan. And and like I said, as we go through these sessions, and I'm really big on work plans. That's the only way I can keep organized and figure out my life, okay? And we're going to work on hot topics, who's gathering the information, who can contribute, and who can validate. So those are the parts of a work plan. And in work processes, they may be short-lived. They may only be, a couple of months. They may be all year. So I'll give you an example of something that is all year, and that's your fall risk assessments. So that those are done on a monthly basis, updated. When people decline, you activate the intervention that goes with the decline. You get the orders to match, you document, you order PT in, and then PT documents how they're doing, then they get stronger, then you can roll it back to their previous level. Or if they can't make it and they're getting more and more skilled care, then you activate an action plan for them to move into skilled services. So that's an example of a work plan that is constant. A short-term work plan may be in your maintenance world. You have a pipe break. So you let the maintenance man know that the pipe broke. The maintenance man reviews it, says, oh, I can't fix this. He calls the plumbing company. They come in, they do their thing, and then it's all working again. And that's a short-term work plan, knowing your limitations and when you have to get a third party in. So work plans can be very, fluid and very long, or they can be very short. So let's look at some other concepts. So I know in my behavioral health homes, pizza is really big. They love pizza. And so they look at the menu and they go, we don't want this, we want pizza. So you may say, okay, fine, we'll order 2 pizzas. And then anybody that doesn't want pizza can have what we're cooking for today. And we'll put the leftovers in the containers. And if you don't want something in the future, you can always choose from a container to have an alternative food. So this again is responding to the needs of your residents. You may have a family member call and say, well, how's mom's weight doing? And then you look at the monthly weights and you go, oh my goodness, she's lost 11 pounds. And so you work with the doctor and he may do some labs and say, why don't you add this or that to their diet, like a can of Boost or a can of Ensure. Or we can't do that because I don't want all that protein, so I want to do a non-protein drink. And so the doctor may say, please do not use Ensure. You can use this product instead. So again, it's that adjustment that could be food related. Okay. I've noticed in the last year that we are doing a tremendous amount of snacks and a lot of sugar. Sugar in older adults causes behaviors just like it does in little kids. So I would encourage you to, try to start cutting back on your carbs and snacks with sugar and get back to healthy snacks. Okay. The one thing that's come out of COVID that's very interesting is that they have seen facilities that have a more healthy food life, and they're actually doing 4 to 5 small meals a day instead of 3 meals a day, that their whole community is better and balanced, less sick, and functioning better and tolerating COVID, the COVID restrictions better. Med audits are a must. They are monthly. And so these are just some of the things that people have told me that when they did a med audit that they found, and what's reportable and what you have to write an immediate occurrence report versus that it's part of your quality and what you have to do to mitigate it. And so one of the things that staff again have taken shortcuts is they're not checking the order to the bottle to what's written on the page to make sure they all match. And when they don't match, stop and get somebody that has the authority to get it fixed, including themselves, if they have that authority. And then does the policy match how to repair when the orders don't match? And we've seen that happen. So for instance, the doctor orders XYZ and they want them taken 2 tablets, twice a day, and pharmacy, they're not making that dose anymore. So the pharmacy can only send a single dose tablet and it doesn't quite match the total. And so they got orders, but they didn't send those orders to you or fax them to you so you could update the orders. I see that happen, or they're out of it. They can't get this medication because it's no longer being produced by this manufacturer. So this is a substitute med that you can use. And again, the orders have to match. The PRN effectiveness orders is another one that tends to get people in trouble. And so they will, the staff will give it and they might chart it in the controlled drug sheet, but not on the MARS, or they might put it on the MARS, but never did the follow-up effectiveness. At least electronic records are decreasing that. And that was actually a long-term work plan that was done. And then the electronic health record authors and algorithm makers have helped us so that people can't close out for the day and clock out until all their charting is done. So we put in action steps to try to improve the process and have better compliance. And this is another medication audit is probably one of your top 3 that you have to do. And it's probably one of your biggest headaches as well, is that meds match and that they're meant for the right people for the right reasons at the right time. As I said, PRN documentation, when I work in facilities, I usually find this is a big hole. And part of the holes that I catch is that they're taking it every day at 2 o'clock. Well, get it out of the PRN and get the doctor ordered daily at 2. And then if they refuse it, then you only have to document occasionally. If they start refusing it consistently, then get it discontinued. Okay. If you have inhalers One of the things, I was at a facility and they had 30 inhalers for a resident, hadn't used any of them once when they first got the order and never again since. That's a big waste of our dollars for care of our residents. And I would rather that we take a very active role in PRNs, and that we have a contract with our pharmacies that we will order our PRNs and we'll have them into you by the 25th day of the month, and not just send them routinely. They make big money, and you can't return the meds, and they get to bill the state. Part of what the state is working on is a total overhaul of the pharmacy programs for our industry, nursing homes, and the private sector. And one of the things I've talked to them about is exactly what I'm talking to you about. And so they were actually getting ready to launch a study to find out how many PRNs were actually being filled that were not being used, to see if they could get a handle on the cost up to the state. So training. In this coordination of training, you have some yearly training, and then you have your orientation checklist and your first 30-day training. Make sure that your orientation checklist is in their HR record, and the competency that you have proof that they can actually understand it and do it. When the surveyors go in and ask their staff about training, and they say, didn't you get this in orientation? Well, they don't remember orientation. And they'll say, oh, I never had any orientation. And then the documentation's not there, and therefore you get a deficiency. Same thing for the first 30 days training, and then your mandatory training, state trainings. So whether it is your food and safety training or your first aid and CPR, some of those other trainings, and then validation of those trainings. You want to make sure that staff are comfortable. When your staff are comfortable with how to operate, they will do a better job. And so orientation and first 30-day trainings is a very major expense. What I've heard from the agencies for quite a while is people come to orientation for 2 or 3 days and never show back up. And so that has been a problem that, again, we need to bring it back out and figure out how we can work with the Department of Labor and with the state and whoever else has to be engaged, that if they quit without notice and they only did orientation, that those orientation costs are come out of their check. And maybe we can get some of that behavior stopped, I'm hoping. Some staff have some job specific training they need to do. So a maintenance man needs a different set of training, like OSHA training and some other trainings that are in his world, handling chemicals, how to store chemicals, because they take that responsibility on. So some jobs have specific training. This is kind of what's interesting about this gig worker idea that the state wants our industry to use. So they want you to use specific jobs, train to those specific jobs, and hire the people just to do the specific job. If we actually move that direction, it's going to change our industry, but it could be for the good. I mean, I haven't made up my mind one way or the other, but it's one of the mechanisms that the state is using to try to get unemployment way, way down and get people back to work. All right. Do not forget in your coordination all the trainings that you attend. So document them, have your own training sheet, and then you know your contact hours. So when you come to things that I give or Maria gives, you can pretty much guess that you can do at least one contact hour on that. If you're having any problems, you can always call or email me. Okay. So QAPI is what we're going to be working on for the next few months. And QAPI is Quality Assessment, Quality Action Plan Improvements. So a QAPI says, oh, you identified this issue and it keeps happening over and over and it's impacting us in a certain way. And we wanted to lower that risk, or we want to lower that complaint, or we want to lower that threshold. For instance, I'll give a simple one. Residents, in a behavioral health home was sick to death of casseroles. So they had asked 3 times in resident meetings to get rid of casseroles. And then they came up with menus, and they were pretty decent menus, actually. And the owner did it for a while, and then all of a sudden went back to casseroles. So again, all the work that was put into it went on the wayside when the owner changed and said, we're doing casseroles again. And then the residents weren't eating and the food was going in the trash. So care coordination, this QAPI process, is really important, but we also have to agree to continue it until the feedback changes it again. So your assignment this month, what I'd like you to do is find your documentation tools. I want you to pull your resident service policies and whole section in chapter 7 under resident services. And I'd like you to, see if you're missing any policies. I have a lot of draft policies I've done over the last few years. And again, if you're part of the administrative circle, you just have to talk to me and I will probably just give it to you, okay? And then your training checkoff list, make sure that all your old employees, even if they've been with you for a long time, you may need to do a sprint, a QAPI sprint. That means that you're going to do all the training for orientation for everybody. And you're just going to do everybody that works at the facility is going to do it again and make sure that everybody's on the same page, because you're doing a better updated program and you're building slides and you have the tools. And you may decide to do that, and it might be a good thing. So whatever you do and whatever training you do also should be employee driven. So let's say you have an employee that makes 4 med airs in a quarter. You may send them back to QMAP school. And I've been talking to Lighthouse, because they're one of the QMAP providers, about having a school where people would come in for 4-hour retraining, and then they would do the competency for you. And so they're thinking about it, and I'm hoping they'll take me up on that, because I think we could use it in the industry. So when you're doing a sprint QAPI, that means you got to move on a dime. So when that storm came in the other day, I sent work plans out to a lot of people that asked me for them, and gave them a list and said, just put little notes, little dots. I've got it. I don't have it. Ooh, I better fix this. I need to do that. And then things that you may need to do, like a go pack. Your go packs for your residents, you may not have mold anymore. And so you may need to do a project in it with activities to get go packs caught back up. So a QAPI sprint generally is when you have to respond to an immediate or urgent need. And then general QAPI is something that you can break up into parts or smaller parts until you get it all done. And every QAPI generally stands alone. And it's very rare that they integrate. So I'll give you another example of a QAPI that would have to be coordinated. Let's say you finally get the money and you're going to go from paper Mars to electronic Mars. Well, it takes about 90 days to make that crossover. So you're actually doing both for about 90 days. It irritates people to no end. But the algorithm has to be worked on, explored, adjusted for your facility, and get all the kinks out of it, as you might say. And so when the QAPI is done on that, you have this crossover period. Then you pull the paper and you see if the electronic records hold. And then you're doing a review every week. You're looking at all the orders and all the MARs and all the documentation, and you're running reports to make sure that it's holding at the highest quality level you can get it at. That's an example of a QAPI sprint. All right, so next month, my goal is that we will cover the next 2 elements. I will integrate it into your quality work, and we will talk about what we've talked about for the last couple of months, bring it forward. We will look at data and the kinds of data and how do you collect results. We will also, I want to spend some time on how the grievance procedure and complaint procedure needs to work better. Because the feedback for the whole industry is we're doing a horrible job of validating people's complaints and grievances and doing anything about them. And then we'll look at our concrete tools, our water temperature tools, our food temperature tools, our fire drills, our, did the filters get changed, the maintenance logs, do we have everything gathered that are static or stable and you have to do constantly? And then what are your projects for the year? For some facilities that I'm consulting to them on their QMP hand in hand, we're talking about the different issues that they're dealing with, and then we develop a QMP, and this comes right here at this point. What are we going to actually work on this coming season? Okay. And then we will work on element 5, which is what I call corrective actions. So how do you even begin to make a corrective action? And how do you get it to stick? And how do you evaluate the competency? So next month, I will be concentrating in this area, and probably be a little longer session than this month, because these are both pretty heavy topics. If when I'm developing them, if I think it's too much, I may split it and do 2 different sessions. I haven't quite figured out whether I should have 1 or 2. So thanks for coming. You're always welcome to contact me, email me, call me, whatever you need. Maria and I just did an update on COVID-19. She'll be posting it in social media. And I did an update because things changed right after I did the presentation. And I'll be doing one in April because we already know some things are going to change again. And so please watch that, and feel free to bring your staff on board to watch it and validate them that we've got a little ways to go. We're not out of this yet. So you have COVID-19. And then I'm going to also, the other thing that I've got as an added bonus, you're all required to do training in elder abuse on a yearly basis. So I revised my whole elder abuse training programs. I've divided it into 4 one-hour sections. And so your staff can listen to them at any time. And then I'm going to be working on, I'm hoping to have it finished by this time next week, a little feedback loop questions. And then if you do, the 4 tapes, and then you have the staff do the feedback loops, then I can work with you for certification, and then you will have it for your annual training, for your 30-day training, and then for yourselves on where we are in elder abuse, where are we going as a state. We have grown so much in combating elder abuse. I'm very blessed to sit on a team, and we're right in the midst of it. And then we're working with New York, and we're going to be working with another state. And so states are actually joining hands because the federal government's giving us some financial resources and incentives to work together again, because elder abuse is one of the hot ticket items in the justice, along with racism and some of the other stuff they get to deal with. So thank you for being an active Administrator Circle member. I hope this will continue to grow and be of value.